Hello everyone. Today we will talk about the management of angina pectoris. Any patient who presents to you in primary care with chest pain and you suspect it to be inguinal pain, then give them glyceryl trinitrate. Glyceryl trinitrate is also called GTN and it is basically given to abort the inguinal attack. Its mechanism of action is that it is basically a vasodilator. Here is the constricted vessel because there is a plaque that has been broken and it's blocking the vessel. So glyceryl trinitrate will try to dilate this vessel. So the dilated vessel will then help to decrease the symptoms, the chest pain. The second step is to give aspirin. You give a loading dose of 300 milligrams quickly. Aspirin is basically an antiplatelet. So how does it work? That here's the vessel and here's the plaque. And if you remember that we said that when the plaque breaks off, the platelet and other substances in the blood, they come and attach to it, forming a blood clot. So aspirin will try to prevent these platelets to aggregate along the plaque, thus preventing the progression of the plaque. Usually the patients, when they present with chest pain, they're in distress. So we give them oxygen. However, the new studies and the new guidelines suggest that not all patients, they require oxygen. Only give oxygen to the patient whose oxygen saturation is less than 94%, aiming it to be between 94 to 98%. But if the patient has chronic obstructive pulmonary disease and they are at risk of hypercapnic respiratory failure, then the target should be between 88 to 92% until the arterial blood gases are available. The fourth step is to do a quick ECG, but remember that do not delay the transfer to emergency in performing all these things. Also remember that a first normal ECG does not exclude MI. And finally, you have to refer the patient to emergency for further evaluation and to establish a diagnosis and to be treated accordingly. So this was the summary of immediate management in acute chest pain. Now, once the patient is stabilized, let's discuss that what is the further workup and chronic management of angina pectoris. All patients with coronary artery disease should be assessed for their disease severity, either by stress testing, cardiac imaging, or invasive coronary angiography. Stress testing is the most common method. It will help to secure the diagnosis, it will determine the disease severity, and to gain the prognostic information. The choice of initial stress tests such as with exercise ECG, exercise with imaging, or pharmacologic stress testing with imaging depends upon the patient's resting ECG, also on the patient's physical ability to perform exercise, and the available technologies. Cardiac imaging, such as CT angiography, is an alternative tool for diagnostic and prognostic information, especially in patients who are not candidates for exercise, ECG, or pharmacologic stress testing. In certain situations, we have to do invasive coronary angiography, for example, in patients with atypical symptoms and equivocal findings on stress testing, in whom a diagnosis needs to be established. Measurement of left ventricular systolic function is also useful in most patients to determine the optimal medical therapy or the role of interventional or surgical therapy. Echocardiography also identifies patients who have had a silent infarction in the past and to evaluate valvular function. The management of stable angina comprises of lifestyle changes, medication, percutaneous coronary intervention, and surgery. Lifestyle changes and risk factor reduction should be a central component of the management of patients with angina. These include cessation of smoking and alcohol, physical activity and weight reduction, eating a healthy balanced diet, treatment of hypertension, and good glycemic control in diabetics. All patients with angina should be on the following drugs unless they are contraindicated. The first is aspirin. As we discussed in the previous slide, that aspirin is an antiplatelet agent, So it prevents the platelet aggregation by inhibiting cyclooxygenase and suppression of thromboxane A2. In case aspirin is contraindicated, then there is another drug called clopidogrel. It is also an antiplatelet agent, and it also inhibits platelet aggregation by inhibiting the ADP binding to platelet receptor. Next, we have lipid-lowering agents such as statins. Their mechanism of action is that they inhibit the enzyme HMG-CoA reductase. This enzyme is actually responsible for cholesterol synthesis. So by inhibiting this enzyme, you're inhibiting the cholesterol synthesis, so it will not be able to add up into the plaque in the vessel. Nitroglycerins are vasodilators. They cause relaxation of the vascular smooth muscle by stimulating the cyclic GMP production. They also help in decreasing the blood pressure. Beta blockers such as metoprolol, atenolol, or propranolol block the beta adrenergic receptors. In this way, they reduce the myocardial oxygen demand by decreasing the heart rate and also by decreasing the myocardial contractility. If beta blockers are contraindicated, we can give a calcium channel blocker. Now, calcium is basically responsible for contraction of vascular smooth muscles. So if we block these calcium channels on the vascular wall, then there will be no influx of calcium in the vessels. Therefore, it will cause relaxation of the vascular smooth muscle. These are some additional points which you need to remember about the pharmacological therapy of angina pectoris. If you're using a calcium channel blocker as monotherapy, then you should use a rate-limiting one, such as verapamil or diltiazem. But if you're using it in combination with a beta blocker, then use the long-acting one, for example, nifedipine. Remember that beta blockers should not be used with rate-limiting calcium channel blockers such as verapamil, because there is a risk of complete heart block. Also, if there is poor response to initial treatment, then medication should be increased to a maximum tolerated dose. For example, you started atenolol at 50 mg initially, then you can increase it up to 100 mg OD. If a patient is still symptomatic after monotherapy with a beta blocker, you can add a calcium channel blocker and vice versa. If a patient is already on monotherapy and cannot tolerate the addition of a calcium channel blocker or a beta blocker, then you can consider one of the following drugs. For example, a long-acting nitrate, ivabradine, nicorandil, or ranolazine. These are some newer drug treatments in angina pectoris. If a patient is taking both a beta blocker and a calcium channel blocker, then only add a third drug while a patient is awaiting assessment for percutaneous coronary intervention or coronary artery bypass graft. If the patient has very severe disease and they're persistently symptomatic despite being on pharmacological therapy, then we have to do either percutaneous coronary intervention, where we place a stent in the blocked vessel for revascularization, or we can go for coronary artery bypass surgery depending upon the severity of the disease. It is a more invasive procedure as compared to PCI. All patients with chronic angina require follow-up on a regular basis. It should be every 6 to 12 months, and at each visit, you should take a detailed history from the patient. Also, physical examination should be performed. Do some lab studies such as blood glucose or lipid profile. An ECG should be obtained if medications are altered or if the history or physical examination have changed, so that you can manage the patient accordingly. That's it for today. If this lecture helped you in understanding the management of angina, then don't forget to share it with your friends. Take care. God bless you all.